morning with a presentation from Dr. John Capek, the Executive Vice President of Medical Devices for Abbott. In his role, Dr. Capek is responsible for Abbott's vascular diabetes care, ophthalmology, and animal health businesses. Those are all you see outside of those broken down. Prior to working for Abbott, Dr. Capek served in various management roles in Guidant, including President of Guidant Vascular Intervention and Vice President and General Manager of Bioabsorbable Vascular Solutions.
Is it running or is it not?
He also served as Vice President and General Manager of Guidant Germany and Vice President of Marketing for Guidant Cardiac Rhythm Management Group. Before joining Guidant, Mr. Capek was manager of new product technology at Eli Lilly and Company. We're very delighted to have him with us today, so please welcome Dr. John Capek.
Well, thank you. Can you hear me okay? I'm going to stand here so I can look at my own slides. But I actually, it's a pleasure to follow the Innovation Challenge, because I started giving presentations on PBS 10 years ago, so I actually toyed with the idea of bringing the slides that I used 10 years ago when I was out starting the company and trying to not only entertain interest from the clinical community, but also attract dollars to fund the operation. So it's a pleasure now to be part of Abbott. We have some really nice slides to share, but fundamentally I'm going to go back to what it was like to bring this innovation forward. And I'm going to do that by reviewing some history. In 1977, when Andreas Korczak performed the first angioplasty with a balloon, it started what was the interventional cardiology revolution. And I'm going to define those revolutions in a series of 4 different technologies which have fundamentally changed the practice and the procedure. But some people don't realize that after balloon angioplasty was developed, everyone knew the complications and the issues of abrupt reclosure, intimate dissections and flaps. There was elastic recoil, and a lot of work was done in the late 70s, early 80s to try to address this, what I'll call manifestation of stretching the coronary artery. And the early work that was done was actually done to develop temporary stents. Temporary stents that could address the problems of balloon angioplasty. Some of them were even discussed as being potentially removable from the patient after the first critical 36 hours. And as you can know now from all of the history that's come from there, these ideas never got a strong foothold. But there was some work that continued to develop not only the idea of stabilizing the artery after balloon angioplasty, but addressing these very important issues. So people started to work with metal. Julio Pomaz and Richard Schatz worked with metal at roughly the same time. Companies and individuals were toying with the idea of what at Duke became a fully bioabsorbable stent. Roughly the same time. And actually that work progressed at Advanced Cardiovascular Systems, SciMed. It was progressing at J&J in the mid-80s. But there were some challenges, and there were some very strong, if you will, issues that came up, and many of those issues revolved around the inflammatory processes that happen when you put polymers inside coronary arteries. And this particular article was written in a porcine coronary artery, but there were many other articles which were written around the same time. What I would say is one of the challenges of being an innovator is you have to be willing to withstand the pile-on mentality of the scientific community. And I think generally at that point, virtually all programs in all of the major manufacturers moved to metallic coronary stents, because metallic coronary stents could be more readily manufactured, they could be more readily made biocompatible, and they could also be made with the right structural integrity that was required to address these acute problems of balloon angioplasty. And that really took the world to a permanent metallic stent world. And of course, since that time, there was the third revolution, and that was the idea of adding a polymer to deliver a drug, essentially the drug to stabilize the vessel after the stretch injury of implanting the first stent. And since that time, we've gone on several iterations of what are now very high-performing metallic drug-eluting stents. To the tune where upwards of 3 million metallic drug-eluting stents are implanted in patients every year around the world, and roughly 900,000 here in the United States. And what I'm going to talk about is going back to the first principle and to really challenge, how did we get here in the first place? did we really need that metallic structure to be permanent in the patient? Did we need the artery to be held open by that metal for the life of the patient, when initially the concept was developed to stabilize the vessel after balloon angioplasty? And if you go back to that first concept, like many innovators do, that's the problem statement. The problem statement is how do you stabilize the artery after balloon angioplasty? A side effect of picking metal, a side effect of picking a 316L or stainless steel was the creation of a permanent implant. But never once was it determined that a permanent implant was required. We go back to that first principle and really try to define what it is that we'd like the product to do in the first place. Well, in the first place, we need to revascularize. That's open the artery. The patient is having angina, the patient is having symptoms, could be an acute myocardial infarction. We need to open the artery. But then we would like to, like we do when we implant now bioabsorbable sutures post-surgery, or when we use bioabsorbable bone screws in orthopedics, we want to allow the organ, the structure, to in many ways heal itself over time. We want to go back to things which are more naturally occurring and restoring the physiologic environment to actually allow vascular healing. What allows that to happen is the pulsatile flow in the vessel both axially and radially, and all of the shear stresses that are resident within a more normal and more healthy coronary artery. An additional challenge, though, we have to accomplish is that you need to get benign resorption. So I'm going to come back to this at the end. Really, this transitions us from implanting a metal structure, which by its very design should not change its mechanical properties for the life of the patient, to actually coming up with a device concept where it tries to fulfill in a very programmed fashion these three phases: revascularize with transient support, restore, and then resort. And essentially bring the patient back to a more natural state. I'm going to come back to this at the end as we define now endpoints in some of our trials as we pursue this concept around the world, which are more patient-centric. Having the opportunity to bring the vessel back to a more free state, allowing when a patient's coronary arteries need to dilate or contract, those naturally occurring vasomotion or vasoconstriction, vasodilation to occur, and to actually allow the vessel itself to perform like the vessel was intended to perform when it was in a more natural state. So let me go back to this about innovation. And first is, as I said, I started BBS now a little over 10 years ago when we were a very small team. I actually previously was president for Guidant Vascular, as you heard. Left to do this entity as part of a unique structure. Guidant owned 51% of it. We had outside investors. It allowed us to go to an opportunity of what I'll call entrepreneurship. Right? We were 51% owned by Guidant, so we had a very well-funded investor. But we were 49% owned by outside entities. One of them was Duke. We had some outside funding from some venture capitalists. And it allowed us to go to an environment where we could fail, if you will, fail like any entrepreneurial organization does initially, but recover quickly. And the organization grew quite rapidly through the early years. In 2005, Guidant executed the option to acquire the company. So we came back to being Guidant, and in 2006, Abbott bought the vascular business of Guidant. So we've gone through a transition of this entity, but through all of that, a tremendous commitment to bringing this technology forward, which started here through the years, ramping up through and over 200 people to now well in excess of 500 people that are bringing this program forward. And I'll share with you where it currently stands in both the technical and clinical phase of its development. So what is the device concept? And I think we describe this device concept in several categories. Right? The first category is that you need a balloon catheter, you need a bioresorbable platform, you need something to carry the drug into the patient, and of course you need to pick a drug. Four components. I could describe a metallic drug-eluting stent the same way, and you'll see that on the next slide. Because when we actually do compare what this product concept looks like when compared to Xience, which is the world's leading metallic drug-eluting stent, we use the same drug everolimus, and we use a very similar scaffold design. We actually have a delivery system or catheter, which is built off of one of our earlier catheters. But instead of using cobalt chrome, which is the metal of a metallic drug-eluting stent of Xience, we use polylactic acid PLLA, and over top of that bioabsorbable scaffold, we have a different configuration of PLLA, PDLA, LLA, which actually delivers the drug. And this is what it looks like in somewhat of an artistic rendition down at the bottom. Essentially, we're using a modification of the base polymer to deliver the drug. We deliver the drug, our drug, everolimus, with the same drug dose and release rate that we do with Xience, targeting to get the same tissue PK. So early on, we knew what we wanted in terms of pharmacologic effect. What we had to do, and where most of the innovation comes in the technology, is to develop a polymer backbone that acutely can perform like metal, that can go over the course of time, transition to bring the load back to the vessel and bioresorb safely. And that clearly was the work done by some very skilled and very capable polymer scientists. And if I were to try to describe how we tuned in the early days, what we wanted to happen when, it was really to try to go back to the biology of what was happening in the first place when not only balloon angioplasty was performed, but when actually vessels are stretched. And in this diagram you can see we target the drug elution to slow down this aggressive response. We want the molecular weight over time to slowly go down, which changes the support. So as the molecular weight of the polymer is being reduced, it changes its mechanical properties. And we wanted those mechanical properties to change at a time of roughly 6 to 9 to 12 months in this period of time. When we pulled that from the literature of balloon angioplasty, because for those of you who remember doing a lot of that as interventionalists, it actually was the time where arteries tend to remodel post being stretched initially when balloon angioplasty was performed. And then over the course of time, we want resorption to occur in these outer pieces, really trying to attack and defend against what is the natural body's response to not only being stretched, but having something being implanted in the corner area. So if I go back to the original premises, revascularize, restore, and resorb. Revascularize the vessel, restore more natural function, and then resorb safely over the course of time. And what we've shown down here, these are the time periods during which that happens on the average. And this is the product that, as you saw, and you'll see on the next slide, this product in its early configuration has now been implanted in patients up to 9 years. We did a fair bit of early work, histologic work, and what this shows in a porcine model is the degradation and the removal of the polymer over the course of time. What actually happens in the place where the polymer struts work is you start to see vascular, or if you will, cellular ingrowth into the polymeric area. So it's what we'll call a transitional matrix is being established, during which and over which the course of the time the vessel is reacting and responding in a more natural phase. What we're excited to see, and I'll touch upon this at the end, is that we can actually create neomedia. We actually see neomedia being created. And we actually have some very interesting cases now where chronic total occlusions have been treated, where in essence the BVS has been implanted subintimally, and we're actually seeing the creation of a vascular channel. Because there's nothing in that vascular channel now that's holding open that channel in chronic total occlusion that was treated subintimal, other than the vascular channel itself. So where are we in this pathway of clinical? So early on, you can see I mentioned in 2011, we had 5-year follow-up on those first patients. It's remarkable how time flies, at least for me. And we're sitting here in 2014. We're no longer following these patients other than clinically. They're out 9 years. We've got 4-year follow-up on the first cohort B patients. This was a modified design. And I'll share with you just some of the data now that's being presented clinically, not here at the heart meeting, but just recently at TCT on the Extend registry in the first randomized trial of Absorb-2, where those patients are out 1 year. In addition, though, we have fully enrolled the trial here in the U.S. That's called Absorb-3. We're fully enrolled in the trial for approval in China and fully enrolled in the trial for approval in Japan. All of those data sets will hit their 1-year follow-up in the beginning of next year. Right? So we're anxiously awaiting the outcome of those studies, where we'll use those trials to seek regulatory approval in those 3 what I'll call major geographies around the world, and a number of registries that have started up. This is some data coming out from imaging that's happened in patients who are going out now 5 years. You can see, interesting to see, we see actual plaque regression. Not just maintaining the vessel, but the plaque is actually regressing over this time course, which is quite remarkable to see. And we've got now 100 patients who are out at at this 5-year interval, looking at across our cohort B. So this is the Absorb Extend, and this is the data that was collected as a post-approval registry in Europe. These are a propensity matched pairs. Because it was a registry, we didn't actually have randomized data comparing to Zymes. So these are propensity matched patients looking at what I'll call major device-oriented cardiac endpoints. And for those MACE, TVF, TLF, and scaffold thrombosis, we see no statistical difference when compared to a propensity-matched cohort of patients from our SPIRIT trials, which was of course using the Zyme stent. So we're very pleased to see that. And this is what it looks like when one compares it graphically in the primary endpoints of the trial. Absorb First came to really be another post-approval registry where we'll have now almost 1,200 patients going out to 1 year. The first 30-day data was presented at the PCT, and with increasing lesion complexity, we're seeing similar performance as we've seen with our Zyme stent. But clearly, the demonstrable data is going to come from randomized trials, and as I said, the first randomized trial was presented just a few months ago, and that was our Absorb 2. But before we do that, we're also working towards thinking about, in a more holistic way, how to define endpoints for these trials. Because we've had an observation through the course of our clinical investigation that for reasons that may be in different buckets along the various time course while Absorb is absorbing, we actually have observed first in our registries, and you'll see here of this trial, an actual reduction in patient-reported angina. Not what has historically been the hard endpoints of interventional trials like target lesion failure, target vessel failure, or major adverse cardiac events, but reports of angina reduction. And it has a lot to do, in our belief, of the design of the stent or the scaffold, the delivery of the scaffold into the vessel, but also the highly conformal nature of the scaffold and the way that the scaffold interacts with the coronary artery. So we define these now as we move forward in a couple of our trials, one of which has just recently started in the U.S. called our Absorb 4 trial, which is going to be another 3,000 patients, where the primary endpoint of that trial will be angina reduction as a co-primary endpoint to the more hard endpoints that we've seen. We're going after angina reduction, and for those of you in the pharma world, that's not uncommon because that's commonly the endpoint of a lot of pharma trials, angina reduction, patient-oriented endpoint. Requires us to collect data in a much more detailed fashion, but I think if we're going to move to patient-oriented clinical endpoints, we're going to need to investigate this more. So these were the results of Absorb 2. Randomized 2-to-1, patients receiving our Zymes Prime, which was the version of Zymes available in international, versus the 335 patients that received Absorb. And this at the highest level are the endpoints of that trial that were just recently reported and published simultaneously in JAMA. So we see very similar performance in our device-oriented cardiac endpoints. We see very similar performance in our patient-oriented clinical endpoints. We see almost reaching a statistically significant reduction in revascularization, however, when one compares the 1-year follow-up for these two patient cohorts. In addition, as I said, we've seen this anecdotally in the registries, but we saw here in this trial a reduction, statistically significant reduction in patient-reported angina during the course of their 1-year follow-up. And in this particular case, the numbers, just to orient you, this 16.4 is one of the lowest numbers that we've seen. I don't have a slide in the deck. It's almost back to the patient-reported angina rates that we saw with balloon angioplasty. For most trials of stents, whether they be metallic stents or whether they be drug-eluting stents, we've been living with patient-reported angina rates at about 25%, independent of whether the stent was metal drug-eluting or whether the stent was metal non-drug-eluting or virtually across all device manufacturers. So, we're very pleased to see for the first time we come down to a similar rate that we used to have in the days of balloon angina. And when one looks at that, and I just pulled a few of these for comparison. So this is optimal medical therapy, the COURAGE trial, the RETA-2 trial, and then through PTCA, BMS, DES, comparing the repeat revascularization rates and angina at 1 year post. So we'll keep marching down. Clearly, this is actually the DES arm of the Absorb 2 trial, a very similar result that we saw with Xience, as we've seen with Xience in other DES trials. So of course, this is data that's being collected as part of the pivotal trial for approval here in the U.S., as well as data being collected in our Japanese and China approval trials. And clearly, this is not just about reducing angina for the sake of reducing angina. It clearly is something that, from a patient standpoint, is important. But when you model out the resource utilization, it's not only of seeing a lower rate of angina in the first year that needs to be differentially diagnosed by the healthcare system, in addition to substantially lowering revascularization rates, which are generally performed in the first year after the index procedure, we could see a substantial savings to the healthcare system. And this is just modeled out at the bottom per 1,000 patients, but clearly with 900,000 patients receiving procedures here in the U.S., it scales up to a very significant number. So where are we in the world of not only being commercially released, but moving through clinical trials? You can see here in the color chart, we're clinical phase in yellow, we're in special access where the product's available with specific patient-oriented requests by physicians, predominantly up in Canada, and we're commercial in the areas marked in green. Current implant levels for Absorb in total are now moving past 70,000 patients being implanted, and we're roughly implanting 8,000 to 9,000 Absorbs every month. So we're increasing substantially our experience and understanding of this product as we move through various phases of commercialization. So there are a couple of unique aspects to what a BVS does and how a BVS does it that makes it different than a metal stent. And some of that is coming out in the procedures that our international physicians choose to prioritize for implantation of a BVS, as opposed to implantation of either a metallic BVS or even traditional VMS. Long diffuse disease, where physicians are concerned about creating a full metal jacket, well, you, for a period of time, have a full polymer jacket. But over the course of time, you won't, because as the device resorbs, there's nothing left behind in the patient, which allows then that vessel, if something subsequent to the initial index intervention needs to be performed 3 years later, 5 years later, or for some younger patients who are 50 years old, 20 years later, the metallic implant is not complicating the subsequent reintervention that that patient might need. In addition to some of this, we see the opportunities, and this late lumen gain has been well published, and not only in our porcine models, but now in people, that we do see vessels in people want to get bigger after that 6-month period. And that's something that's not possible when you implant a permanent metallic cage. The vessel cannot get bigger. Yet, oftentimes the patient vessel wants that. We don't gel side branches long term. I mentioned this plaque regression. There's another very important factor. We came up with this very early on with the advent of MRI imaging, CT angiography imaging. You can see perfectly through a BVS. There's no plume, there's no obstruction of image, and as more and more people are considering CT angiography as a means of following patients longitudinally, that's much more possible in particularly small vessels with this technology. And it preserves the natural anatomy. And we are now just starting, so many of you may have known, historically we started a trial called Prospect. Prospect was meant to identify the propensity for a vulnerable plaque to rupture leading to an index event in a patient. We early on investigated this in a fairly elaborate trial here in the U.S. I think we came to conclude that a permanent metallic drug-eluting stent was not going to be the appropriate therapy for treating those tick as they were called, if in fact you could even identify where. But we are revisiting this concept now in a trial that's going to start here in the U.S. that we call Absorb Prospect. It's going to look at the potential to actually, instead of just using an intervention to remove an obstruction, to actually use the intervention to remodel the vessel itself, to put it in a more stable place so that it perhaps would not rupture in the future, causing a heart attack for the patient. And I'll end with this slide, and I think and I'll also make some comments about where the technology goes from here and challenge some of your thinking. If you actually do now take a look at and Google bioresorbable scaffolds, we find bioresorbable polymers being used in heart failure. We find bioresorbable scaffolds being used to remodel mitral aneurysms. And that's being driven by, I think, fundamentally an understanding in polymer science that we didn't have as an industry 10 years ago. We definitely didn't have it 20 years ago, and even over the last 5 years. Our rate of understanding of how to process a polymer to perform like metal acutely and to bioabsorb safely in the body. And it may or may not be functioning as a drug carrier, but the state of understanding and knowledge in this field is growing, not necessarily exponentially, but surely geometrically. So you can imagine as when I was starting BBS, I got the question, because we started BBS without a product in mind. Why didn't we do a product for peripheral angioplasty? So SFA disease, clearly if we can form like a metallic drug-eluting stent in the coronaries, we should be able to figure out how to allow this concept to work for patients in their peripheral anatomy. And if it can work in the leg, we should have the opportunity of understanding how can a technology work this for cerebral occlusion. In addition, I would also challenge our thinking to say, if we think of products today which are permanently implanted, but not necessarily to be permanent, or where the fact that they're permanently implanted, it's a problem for the patient. One can come up with a long list of pediatric applications where today's permanent solutions are not the best because the device or the solution needs to grow with the patient. We have that opportunity with polymer. I think there's several other PFO closure devices or things where we could consider they're metal today because metallurgy has been a big influence in science. They can be polymers tomorrow. I think innovations over the next 10 to 20 years are going to be driven by this influx of understanding of how to process polymers. May or may not be drug-eluting. I also believe somewhere in the next 20 years you'll see what I'll call maybe the fifth revolution. If you consider what an absorb does today, right? An absorb is a scaffold which delivers a drug to deal with the inflammatory or response to stretching the vessel. It's a drug application on a device to address a problem of the device, or a side effect, if you will, of the device. Well, one could also take it to the extreme. Now I know how to deliver drug from an implantable object and have the implantable object go away over time. At its extreme, it's an implantable pill. Today, the primary therapy is the scaffold to open the vessel. The drug is being used to stabilize the vessel after being opened, and then the pill is bioabsorbent. But I could come up with concepts where the primary therapy is the drug, and the means of delivering the drug to a targeted site is the scaffold. That is scaffold-facilitated drug delivery, not drug-facilitated scaffold delivery. And I think this concept allows us to consider innovations further on. And with that, I know I tried to keep to my half hour. I want to thank you all for your attention. And after lunch, if people have a question or two, I'd be happy to take them. Thank you very much.
We actually have a couple minutes for questions, so if anybody has any, please, yes.
Hi, I'm not a clinician. I work for the Heart Association. Do you have the slide on the 5-year plaque regression?
Plaque regression due to the absorb stent. What do you make of that regression versus obviously having the implanted stent permanently? Because it's obviously more than the medication, right? You don't have scar tissue developing around the metal stent. But what do you make of that 5-year progression? It seems like a huge value add. But talk to me a little bit more about it.
You said it in a certain way. I'm not sure I can claim that the plaque regression is due to absorb. I think we've not observed this same observation behind metal implants, because I think the metal implant is preventing the vessel from doing what the vessel wanted to do, which actually may be the mechanism by which the plaque is regressing. I don't think it's the absorb doing it as much as it is the absorb allowing the vessel, in some cases, to actually do it itself. I think in a transitional fashion. I think If you think about what Absorb is doing, is it's slowly over the course of time allowing the vessel to receive the load back of being an uncaged vessel. Think of it as you're taking the cast off your leg slowly, as opposed to abruptly removing the cast, bringing that load back.
Right, and what would happen for again if we
So whether it's the shear stress, whether it's the pulsatile nature of the vessel, whether it's axial or radial movements that are now becoming more natural, I don't think we know the answer. I don't think it's Absorb doing it as much as the metal's not preventing it.
Any other questions? Very good, thank you. All right, well, it's now my pleasure to introduce Dr. Gene Kim, Assistant Professor of Medicine at the University of Chicago. Gene is a close colleague of mine. He's sort of a triple threat guy. He does a lot of clinical work in heart failure and transplant. He's also been an early adopter and researcher that's been funded by the AHA in microRNAs. And I thought in this particular venue and for this particular topic that Gene would be a perfect person to come up and just give us a few details of how funding from the AHA has helped him and his research. Gene.
So I promise there's not going to be any slides of data that you may or may not want to see. It's more of a general talk about why funding is just so important to what all of us do and ultimately what we want to do. As Marty had mentioned, I'm a heart failure cardiologist, like many people in the room here, and so I really stand, I feel like I'm standing at the cutting edge of all of medicine on a disease that is very insidious and very deadly. And it sort of manifests itself in many ways. I can send my patients to my electrophysiology colleagues for the most advanced rhythm management advanced devices for electrical problems. I can send my patients to the cath lab for interventional support, short-term mechanical circulatory support, and often I have to send my patients to the surgeons for long-term circulatory support or even cardiac transplant. And so there's a lot of state-of-the-art technology that I have to employ, and I think what we heard about this morning is even another front in the clinic. What sort of innovative technologies are we going to be able to use for our patients? And so as you stand here, you sort of appreciate a lot of the technology. What's still very evident to me, and I think to a lot of us in this room, is that there are still lots of gaps, large gaps in our knowledge and understanding. And you can ask the questions very generically or sometimes very specifically, but for example, do we know who is at the highest risk? And I'm not just talking about sudden cardiac death or multi-system organ failure or progressive heart failure. Do we know about who is about prevention of heart disease, as we talked about before? What about family histories of patients who have devastating heart disease? Do we even know which individuals will get the most benefit from some of these therapies? And are we using this state-of-the-art technology to the fullest potential? And I think those are just some of the few gaps that we have. What I do in my lab has a lot of different focuses. You can talk about some of the very basic molecular research that I do. I like to study microRNAs, and for those of you who know or don't know, these things were essentially 15, 20 years ago regarded as junk and discarded because they are so small. And you're talking about a genome that contains 3 billion base pairs. And these molecules, which we all have, in our genome themselves, are 22 nucleotides, so they're very small. So it's easy to see why they would be discarded. But they're very powerful. And what I've found, and what many people have found, is that they are very critical regulators of essentially any important biological process, and that includes heart failure, that includes arrhythmia. And just as a quick, a little aside, some of the mouse models that I've developed, what do these mice have when you just slightly alter the expression of one of these microRNAs, you get heart failure and arrhythmia. And I think some of this data is going to be presented at the AHA, and it's an exciting forum to talk about this. But beyond that, I think some of the other research gaps have to exist, not just in mice. I mean, a lot of the gaps is how do you take something that happens in a mouse and then try and apply it to a person. I think obviously those are two different biological systems that we have to take into account. Do we know everything about heart muscle and all the properties that go along with it? And one of the important things that I do is we take specimens, precious specimens from patients who undergo cardiac surgery and try and understand some of the markers of injury, arrhythmia, or even some of the scaffolding issues, the extracellular matrix that is altered in these hearts, and try and get a better understanding of whether or not hearts can be recoverable. And we see some of the data today about how you can recover a heart using the therapies appropriately. Outside of molecular markers, there are also ways that we can try and model some of our devices to try and best utilize them. So can we use the state-of-the-art imaging technology or hemodynamic monitoring to best get the best performance out of some of our left ventricular assist devices? And this is, again, work that our group is doing to get a better understanding about using all of this state-of-the-art technology. And on sort of a more global, on a broader scale, as we heard about from Dr. Cook earlier this morning, I mean, there's a lot of challenges that we haven't met on the genetic landscape. And I think, as was discussed earlier, yes, there's a lot of limitations of whole genome sequencing, but I think that technology is coming to light, using supercomputing. Getting the data is also very important. And so some of the colleagues that I have at other institutions, what we're doing is we're trying to collect genomes and do whole genome sequencing to see if we can sort of overcome some of those gaps in knowledge. So to talk all about that is really sort of just part of it. Really sort of the more important message is what is the role of research funding and what is the role of the American Heart Association in that. And it's impossible not to talk about this and not sort of be reflective on my own career. I mean, I can essentially point to every single aspect of my research career, my research focus, and it always comes back to the American Heart Association, because along the way, I think whether it's labs that I've worked in, they've always had funding from the American Heart Association. And even as I stand here now, I have very intelligent, bright people, probably smarter than me, in my lab that have American Heart Association funding, doing very important work. So it's one of the ways in which we try and study the diseases that affect us so intimately. And what funding provides us is multiple. It's not just resources. It's not just time away from busy clinical practice. It's also time to train the next generation. Because let's face it, we're not going to answer some of these questions in the next 10 years. We need to keep trying to train the people to ask the intelligent questions and try and bring some real solutions. And I think the other thing that funding provides, to be perfectly honest with you, is it's for the patients. And I mean that in somewhat of an altered, different way. When I consent some of my patients, I will just approach them. I sort of, maybe I'm somewhat unique in this, but I feel like I have to consent my patients myself. And when I ask them, and I talk to them about these studies, one of the things that I say is, I don't know if this will benefit you directly, but it's for the future. And what's uniform in that is the patients almost always say, you know what, I know this isn't about me. It's for those who are going to have this or have it now. And if there's a solution that could be obtained, I want to be a part of it. And so I think some of the funding is to actually allow patients to have some sort of say in the fight for any sort of heart disease, particularly heart failure. So, again, when you talk about funding, I think you can't do the research without the funding. I think there's many reasons to keep working forward and trying to answer all these questions, but we can't do it without the funding. So, with that, I'll end. Thank you very much.
Thanks, Dr. Kim, and thanks, Gene, for being here today and giving us a few of your personal interactions with the AHA and your funding needs. So we've heard a lot of things today, and really in the ecosystem of just research and development and trying to solve problems, you've seen a lot of different avenues to get at that. You've seen a lot of different stages at which that is at. And really, I think my perspective in being involved with the AHA has really been that, the AHA is a great platform to kind of intermix all these things. And all I heard this morning was, we've got to break down these silos and be, much more communicative to one another. And you could see in the early stage presentations that it would be nice to have them be able to have a resource towards certain expertise in order to bridge some gaps and some areas that weren't as developed in their presentations. So at this point, a large percentage of meritorious research goes on funded each year, and the AHA is actually the #2 funder of medical research in the nation, behind the national government. And although the Heart Association funded 978 new research awards last year, we didn't have the additional $163 million to cover the 1,200 other highly meritorious. This is after peer review merit has been assigned. And so the fellowship applications and the research went unfunded. So that's a critical gap that would allow for us to solve a lot of the problems that we've been talking about today. And also to fund is, and I think Gene made an incredibly important point, that a lot of the early stage investigators in a developed investigators lab like Gene are being funded through the AHA, and I think that's a stage that gets them trained to answer a lot of these questions and to move forward from a junk idea to a very highly respected idea at this stage 15 years later. So I'd like each of you to consider joining me and the rest of the executive leadership team by making a donation to the American Heart Association to help us close that gap. As a committee of volunteers, we believe in this cause so much that 100% of the ELT, every one of us actually gave a personal contribution. It really isn't, it's anything is valuable to us and to our cause. If each person in this room donated $100, we'd be able to fund one pre-doctoral fellowship to help a medical student start a career in cardiovascular research. That's huge. That's a big deal, and it's something that's easily accomplished by this group. You'll find a donation card on the table in the American Heart Association envelope to ensure that the most promising research makes it in a translational sense that you heard from Gene today. Gene's really a fine example of a translational researcher. So if you'd like to join me in the Corvita Society with a gift of $5,000 or more, please check the Corvita box on the donation card. And if you can make any donation at all, please feel free to do that today. And strive to fill out your forms now. Don't look at me, fill out the forms. Or go get something to eat. So once you've made your donation, please hold your envelopes in the air, and the Heart Association staff members will come around to collect them. Everyone who donates today will receive an American Heart Association lapel pin as a thank you gift, and we'll give you a few moments now to make your contribution. I see a lot of hands up.
Okay, thank you.
A lot of pens working there.